Well, our last session for the day, such a rich day of activity. Israel, Sweden, the Netherlands awards. And for our last panel, we have Maureen Lewis, CEO of Aceso Global, to talk about the healthcare in the United States and its funding model. We also have Claudio Lottenberg, who is the chairman of IBRAVS Hospital and Coalizao Saúde. He's the moderator. We have Gonzalo Vecina, former chairman of ANVISA and also professor of the Medical School of University of São Paulo. André Médici, he's a member of IBRAVS and editor of Health Monitor blog. And we have here them all to talk about that. Before we go into our Pronep room, our raffle finished now at 4:30, and after the discussion, we are going to let you know who was the winner. Our topic is health in the United States and its funding model. Let's do it then. Good afternoon, everyone. It's a pleasure to be here, to be part of this FES 20. This is a constant event that we have every year to discuss about health in Brazil, something which is constantly inspired in models coming from abroad. We know that all clinical practice depends on the valuing of everything that concerns value medicine and funding models, which are extremely important. Right now, we are discussing a number of intriguing questions, things that take into account the good use of technology and also the increase in life expectancy. Today, we have the privilege of having our keynote speaker, Maureen Lewis. She is the CEO of Aceso Global, someone who is going to be instrumental in sharing her ideas with us today. Two discussants, dear friends of mine with whom I have constantly worked with and whom I admire, André Médici, everybody knows him, as well as Gonzalo Vecina, no introductions required. Said that, with no further ado, let's go for the key presenter. So let me hand it over to our keynote speaker, our dear friend, Maureen Lewis, please.
Thank you very much. This is indeed a pleasure to be here. It's an honor to be part of this group and to be on such a distinguished panel. I have great admiration for all three of you, and you provide leadership in Brazil that few others have done. So I'm doubly pleased to be here, and I'm always pleased to work on Brazil. I just wish I were there instead of in the United States. This coronavirus is not being helpful in that. So I would like to turn to my slides to try to explain a little bit about the United States healthcare system. It's rather complicated by almost any standard, but I think we can get through it with some slides that explain some of the key parts of the system. Slides, please. So first, I'd like to give you a sense of where I am coming from. I've worked on Brazil since 1990, and I've worked with different levels of government. I most recently did a program for Fiesp on the issues of the future of the Brazilian health system and what can be learned from elsewhere and what should be prioritized. So I'm still waiting for the slides. Is that possible to load the slides? Because I think the slides are rather important. Okay, so thank you very much. Next slide, please. Okay, so Jerry Laforgia and I have worked in Brazil for many years on hospitals, on the healthcare system, on payment and delivery. And most recently, a good deal on accountable care organizations. And we've also worked for INVISA as part of our work. So that gives you some context of my understanding of the Brazilian healthcare system, which I think is important to bring the US system in context for Brazil. Next slide. So how do you characterize the US system? First, it's a little bit difficult to understand. And I've been to events in Brazil where people talk about CMS and no one knows what they talk about. We'll get to that. It's very fragmented. It's disorganized. In the same way, I think that Brazil has a bit of disorganization and fragmentation. Partly it's the public and private overlay, and partly I think large countries end up having more fragmented systems. It's costly in the US compared to other rich countries. It's very highly variable in terms of quality. We have the best in the world, but some very poor quality. And like Brazil, it's innovative and dynamic. And I don't know too many countries that are as innovative as Brazil and the United States. And I go around the world and explain the innovations in Brazil because I think there are a lot of cutting edge things that come out of Brazil that are relevant. And that's true for the US as well. And I think there's a lot that the two countries have in common in this area. And there's a constant learning and adapting in both the public and private systems in the United States. I think it's one of the characteristics, and I think it's linked to the innovation that we show. And I think Brazil can learn from some of the US mistakes. So hopefully this will be helpful. Next slide. So let me go over the overview of the financing and payment system in the United States. Next slide. So the mixed system is explained here. This is a complicated graph, but I think it's one of the best that I've seen for explaining how the system works. First of all, I think it's rather surprising that about 45% of all spending is public and the rest is private. So the public system plays almost the same level of expenditure role that it does in Brazil. The main providers of public care are the Centers for Medicare and Medicaid Services, which is in the middle of the public financing. It says CMS, Medicare and Medicaid Services. Medicare is insurance, public insurance for the elderly. Medicaid services are for the poor, and they are done jointly with the states. So the states and the federal government fund Medicaid. Medicare is all federal. On the left of that are the selected agencies. All of you probably know about CDC and NIH and FDA and these other agencies. They are part of the public funding, but they do a very different thing. So aside from Medicare and Medicaid is a child health insurance program, and together they provide services via private providers, very few public providers, and some of the patients are in managed care organizations that are private. And all of the pharmacies are private, and the providers overwhelmingly are private. So that's the important part. On the private sector side, they're private insured individuals. Roughly 80% of the population has either private or public insurance. It's either from employers, as it is very similarly in Brazil. It comes out of federal or state insurance that is going through the private system. There is state insurance commissions that play a role as regulator. The states regulate all healthcare, not the federal government. And they also play a role in regulating private insurance and in private provision and pharmacies. So that's on the regulatory side, and regulation is very strict in the US. The federal government regulates Medicare and Medicaid providers, but not the Medicare and Medicaid services themselves. They are regulated mostly by the US Congress. So this gives a sense of where the money flows and what pays and how the money moves through the system. And as in Brazil, you can have multiple sources of insurance. You can have social, you can have private. So you could have Medicare, Medicaid, and private insurance and state support through state insurance programs that they sponsor themselves. So there are lots of flows of money, and part of the fragmentation is that money comes from the federal, the state, the municipalities, and sometimes counties. So and every state is a little bit different. So that's, I think, part of the reason it is so difficult to understand the US system, because money comes from many different places. But I think what is relevant is that there are a lot of payers, there are a lot of sources of finance, their providers are almost all private, and regulation very strict. So next slide. Next slide, please. So we have I will just repeat this just repeats what I just have said. What I didn't include was TRICARE, which is just for the military, and the Veterans Administration. And Veterans Administrations is like direct management the way it is in SUS. It's publicly provided and probably publicly financed. And then there's private insurance. So aside from Medicare and Medicaid and the state and municipal funding, there is Obamacare. And Obamacare was added because roughly 9% of the population does not have insurance. And this was a way to provide, at the state level, subsidized insurance to those people. As you know, this is a very controversial issue in the United States. Today, the Supreme Court refused to strike down parts of Obamacare. So it will be rebuilt under the new administration, but it's not exactly clear how. But it was a very effective way of improving coverage for some parts of the population. Next slide. So who is buying healthcare? So most of it individually comes from private insurance, Medicare and Medicaid, which is the public insurance, and then 11% out of pocket, and the others are relatively small. So it's heavily those three groups. Next slide. So then the question is, who is ultimately paying? It's households, because they pay through co-pays and also through jointly paying for insurance, even with employer-sponsored plans. Private businesses also end up financing part of it as a benefit for individuals, and then the federal and state government. So that's and other private is basically the paying out of pocket providers. Next slide. So the breakdown of what households spend, most of it is wage-based taxes for Medicare. So Medicare is for the elderly, and you pay as part of all of your employment. There is a wage tax for Medicare for any employment that you have in the United States, starting from the day you begin to work. Then there is direct purchase insurance premiums, which is out of pocket. There are employer-sponsored insurance, which is 27%, and then out of pocket is 36% for those who either have copays, which are very common. Almost all services have copays. And so it ends up being a little bit over 1/3 of all spending is the out of pocket, which households spend. Next slide. So if we would summarize the insurance coverage by type, it's the millions of beneficiaries, and there is more than the population of the United States, because some people have multiple coverage. So the private employee sponsored is the blue on the left, and Medicaid and Medicare you can see, and then the uninsured are 30.7 million people, which is about 9% of the population. So that gives you a visual of the breakdown. Next slide. So who are the largest private commercial insurers? I think that's interesting. So United Health Group, which is partly sponsoring this conference, is a major private insurer based on revenue and membership. And they are also those with the total premium and market share. So they have 14% of total market share in the United States, which is quite large. And in terms of market share, Kaiser Foundation, which many of you will know because of the HMO movement, came out of Kaiser Foundation, and they still are a gold standard for much of the care delivery that goes on in the United States. And it's still a very large proportion, especially in the western part of the United States. So revenue is on the left-hand side, and again, United Healthcare is by far the largest, followed by Anthem. So that gives a sense of the large commercial insurers in the United States. The plans that they provide are highly variable, and we'll talk about that next. Next slide. So what is being spent on? Like in Brazil, the largest category of spending on the bottom is hospital care, and that is over $1,000 a person, and that's followed by physician and clinical services. So that's not so surprising. But I think what has been growing has been retirement facilities and other kinds of personal care services. and home healthcare has exploded. And like in Brazil, the telehealth has really expanded, and that home healthcare expansion is likely to grow because it's tied to telehealth. So that's what it looks like today. Next slide. So how does the financing flow? So you have the Veterans Administration with direct administration, and then you have private insurance, Medicaid, Medicare, other insurers, and out-of-pocket, all going to private providers. Military providers are public, private providers obviously are private. So that gives you a visual of how the public monies and the private monies are going to private providers. Next slide. So the common types of insurance, and this is something that is distinguished in the United States quite a lot. So traditional, in what is called indemnity insurance, where you get reimbursement for claims, it's essentially a fee-for-service system. It's the planos that you have in Brazil or in Sul America or Bradesco, which are a particular kind of insurance. Then there are the preferred provider organizations, where they have defined provider organizations that can be used, and there are discounts for using those, and the co-pays are lower, and there's a very high incentive to use them. Then there are closed systems like you have in Brazil. You have many in Brazil. The Health Maintenance Organization, which are restricted, and they focus on primary care and integrated care. So the difference for beneficiaries are essentially what the premiums are, the deductibles, the coinsurance, and the copayment. So the coinsurance is that you pay up front, the copays at point of service, and what kind of specialist referral is restricted, and then what the provider network choices are. So there are some hospitals you can and cannot use. There are some other providers you can or cannot use. And that has become very, very common, and it's the largest single part of the system, which I believe is on the next slide. So this is, I think, a very telling summary of what's happening in the United States. So in 1988, 73% were like Sul America and Bradesco, and today it's about 1% of total. And that's been true since about 2009. So that part of the market has become very small. And what has grown are the HMOs have actually reduced in size. We can discuss why, but it has much to do with their restrictions that were taken to court and challenged. And then the PPOs, which is the preferred provider organizations, are the single largest source, and they have been for quite a while. They're very popular, and they keep their importance. So the growth here is in what they call high deductible plans, which is on the very right-hand side. It's now 30% of the market. So they have high deductibles, which means that you have to pay out of pocket to a pretty high level before that starts to work. And essentially, this is catastrophic care coverage. That's why they're popular, because they're cheaper and they're geared just to catastrophic care. So it's very interesting that this direction of the market, it had to do with rising costs with fee-for-service under the traditional indemnity insurance, and the fact that you can get cheaper services with arrangements with certain providers under the PPO model. So that preferred provider model is quite important and has remained quite important for insurance in the United States. And I think it's quite telling about the directions of what's happening. Next slide. So what are the highlights of delivery? I think it's useful, even though I was asked to talk about financing, to talk about the provision and some areas that are quite different than what we see in Brazil. So first of all, on the left-hand side, the regulation of providers. Regulation is quite serious in the United States. All providers are licensed, nurses, doctors, even physical therapists. All of the providers are licensed. Every hospital has Joint Commission accreditation. If you do not have Joint Commission accreditation, you cannot be reimbursed by Medicare and Medicaid. You cannot serve those patients. So 99% of facilities are accredited, and then but there's no accreditation for rehabilitation hospitals, which are actually shrinking in some respects because of post-hospital care is being done more and more at home. The second area that I think is really important is the proportion of nurses versus doctors. In the United States, we have 891,000, a little more than 891,000 physicians, and then we have 3.4 million active nurses. And we have a shortage of nurses in the United States because nurses do things that are done by physicians in Brazil. They are increasingly independent. We have a wide range of the types of nurses, from nurse practitioners that can do many of the things that junior doctors do, to helpers who are more similar to some of the nurses in Brazil. So I think these are two areas where there's quite a bit of difference between the United States and, frankly, most of Europe and Brazil. So next slide. So one of the things that is the United States is sort of obsessive about data, which has its benefits. I think that part of the reason that DRGs were developed was because they provided data as well as incentives for reducing unnecessary services. But one of the things that we are finding, that the integration of data with the financing, with the reporting and analysis, with regulation, with delivery of services and electronic medical records, prontuários electrónicos, are very much integrated. And where they're not integrated, it's a problem for management, because there's a big management component. As healthcare has gotten more complicated and more costly, this data and management component has become incredibly important. And where the challenges have been in the United States has been on interoperability, to make sure that the systems talk to each other within one system. The second thing I think that is very instructive for Brazil is that there was a mandate under Obamacare to have electronic medical records. So everyone did it, and they didn't do it well. And so it has defeated the purpose of the electronic medical records, because they're not integrated. They're not integrated across levels of care or across providers, and they've been done poorly in many places. I think data have become essential. The oversight of the Medicare system is all based on data, reports and analysis that go to Congress on an annual basis, and the budget is based on that performance. And that data is an adjustment. And I think it's worth noting that Medicare uses DRGs, and they started DRGs at the same time that Brazil started using the IBRAVS system. But they've gone in different directions, where the US has used data more and has built on that system. And I think that the IBRAVS system is not quite as robust as it could be. Next slide. So what are the trends in provider payment? How do we shift to value? Value-based care is clearly a mantra in Brazil. It is in the United States as well. Next slide. So what is the catalyst for new payment models, which is the value-based care? It's the increasing cost of healthcare. And you can see the historical rise in total healthcare spending and what the projected is. And the projected is a little bit less steep than the other, partly because of initiatives. Next slide. The second reason for this is that there were studies of waste, looking at fraud and abuse, overtreatment, low value care, failure of care delivery, poor pricing, and administrative complexity that made it very difficult to oversee what was going on. So inefficiency was estimated at 23 to 29% of total healthcare spending. That was the second catalyst. Next slide. The third catalyst was poor quality. In a study in 2003, there was a study of adults who received healthcare services for 30 specified conditions. Only 55% of them received the right care, based on an expert panel. And these quality problems led to some seminal work on crossing the quality chasm, and other reports that basically told the country and the government that the quality of care was too low and was unacceptable. Next slide. So the tradition of how you pay is really fundamental. And I think one of the things about value-based care is that we've learned that if you can focus on reimbursing for value rather than for inputs, there's value. That's one part that I think is very important. Secondly, you have to have information on results and outcomes. And finally, you have to have risk sharing with providers. And that is, I think, the biggest challenge, but that is the direction that we're going in the United States. So next slide. So the value-based payments is really about incentivizing prevention, quality, patient satisfaction, controlling costs, and sharing risk. So next slide. So essentially, there are three main parts to the value-based healthcare payments, and that is defining what you're going to measure, measuring those outcomes, and paying for results. And when you pay for results, the risk sharing is that the providers share the risk for not oversupplying and not providing poor care. So that risk is that they don't get paid adequately if they don't perform adequately. So this is a very different model, and I know this is being discussed in Brazil in many different ways, but I think these are the three big parts that define the basic concept, and the shared risk concept underlies this. Next slide. So what types of alternative payment mechanisms are there? So we've talked about DRGs a little bit, but pay for performance, one of the things that the US has learned is that pay for performance is done at the institution or the team level, not at the individual level. It tends to not work. Bundle payments, which has become standard practice for orthopedics, and they're looking there, and some cancer treatments, and also it's being looked at for maternity. Capitation with accountability, and there's a difference between capitation where the money is just provided and everybody hopes that it goes well. With accountability, you have data and you know what's happening if patients are being treated, what the outcomes are. And then finally, a global budget with accountability, which a lot of HMOs use. Next slide. So the US payers are embracing a shift towards alternative models. So fee-for-service is now about a little under 40% of all payment, and alternative payment is growing very, very fast. Because 3 years ago, this would not have been the breakdown. Next slide. So what kind of alternative payments are actually being used? So fee-for-service in Medicaid, which is for the poor, is still fee-for-service, but it's also now increasingly being contracted out to an NGO. It's a little bit like the OS system in Sao Paulo state with the hospitals, except that it includes outpatient care too. So it's that, and then shared savings. And the shared savings means that the physicians that reduce or control costs share in the savings that are produced. And then you have bundle payments are much less common in Medicaid, much more common in Medicare and in the private sector. So the fee-for-service remains important in the private sector and in Medicaid, but is shrinking very fast in Medicare. But I think this is important because it shows that the shared savings is growing, that the shared risk and bundle payments are growing, and that different parts of the system are adapting much faster than other parts of the system. And it's relevant that Medicare has been driving the desire for short-term care. I mean, one of the things that I think is important that I haven't mentioned before about payment, and it's very different than what goes on in Brazil, is the best and the fastest payers are the government, state and federal. They're the first to pay. And many hospitals rely on Medicare and Medicaid because they do pay and they pay on time. So this is in contrast to literally any country I know in Latin America. Next slide. So most alternative payments basically build on fee-for-service. There's provider resistant to taking on financial risks. So as you can see on the right-hand side, the risk sharing is a small share of the total, and most of that sharing is what we call upside risk, which is the things for the things that are where there's good news and there's money to be shared. That's where the risk is being shared, but it's not being shared much less in terms of failures and loss and not having penalties. So this is a part of the evolution of the payment system. It takes time to adjust and to invest in new systems and new payment systems, and they're hard to set up sometimes, especially when physicians and nurses are used to doing things in a particular way. And management becomes a very, very important part of this, that you need the management component to be able to make these alternative payments work. Okay, next slide. Okay, so 90% of payers believe that the alternative payment mechanism will increase and move forward. The US government has been testing models to align metrics, incentives, and to reduce the burden of reporting. One of the things about bundled payments is that administrative costs are low because you're giving them a lump sum and saying, okay, all of this has to be covered. So that's a major contribution. Next slide. So what are the conclusions and implications for Brazil? Next slide. So I think the things that are different about the US is the data use, variety of financing, which I think is true in Brazil as well. The regulations define how the system functions, both public and private, I think making it more coherent. Government has fixed prices and pays promptly. This is not the case in the private sector and is problematic. Private sector has no defined prices and negotiates payment terms and timing for payment, and it must drive the providers, it drives the providers crazy. So those are things that are really important. And in addition, the fact that the US is very expensive, and part of it is that our physicians and nurses are paid more than any other country. Next slide. So what are the implications for Brazil? So the similarities I've sort of gone through, the quality challenges are there. The private health sector is very dynamic and innovative, and I can go through all sorts of things that are innovative in Brazil, but you know them better than I. And alternative delivery and financing models are expanding really fast. And there's the IT and electronic medical records are really a pressure point because that's fragmented in Brazil too. And it's a little bit, it's fragmented in the US too, but it's really something that both countries, I think, would benefit greatly from fixing. Last slide, please. Okay, so what do I see as the challenges of the Brazilian healthcare system that is related to what I've talked about with respect to the US? One is INS is the only legal regulatory body, and it's only for insurance. It's not for provision. There are globally regulations target profits rather than prices, outcomes, and adverse events. And that's not the case in Brazil. And all three of those are probably the best way to move in terms of regulations. There's a tendency to want to control prices rather than control profits. And you want the incentive of profits and to tax that. So that's, I think, an area of discussion. And the lack of accreditation, less than 10% of all hospitals are accredited. That's an issue. Quality requirements are very few. Delivery standards are not standardized. And incentives for payment innovation is limited, especially in the public sector. Public sector sort of holds on to the direct administration. There's inadequate data in public and private sectors. There's obviously exceptions. Albert Einstein and Israelita and some of the other major hospitals, the ANAP hospitals, have really made an effort to do this, but they are the exception, not the rule in Brazil. I think there's a total inadequacy of nurses, and as the non-communicable diseases expand and the management needs expand, nurses become very important. Public and private sectors function in parallel. I mean, one of the things about the U.S. is that the public sector finances not quite half, but almost half of the care, and it's done by the private sector because they do it well. Public sector is not a reliable buyer, so when they do pay, they don't pay well, and that the IBRAVS system that was started in the 90s certainly showed that. And they're therefore not a reliable payer for private care, which is a problem. The public sector lacks consistency in management and accountability, and we can talk about that a long time. I've worked a long time on those issues in Brazil, but I think that there's lots of potential in Brazil, and Brazil is always dynamic and always moving. So all of these things are things that can be dealt with, because one of the things I learned early on in Brazil is once Brazil decides to do something, it gets done. So the last slide is basically thanking you. This was a privilege. I very much enjoyed talking, and I look forward to discussion with all of you. So thank you very much. Muito obrigada.
Claudio,
Nós
now
vamos
he
passar
has the
agora para
song.
uma
Now
parte
we
muito
would like
importante,
to give the
que
floor
são
to
os
a very
comentários, as
important part, which are
observações
the
de
comments,
dois
the
experts
remarks of
que
two
conhecem profundamente o
experts
sistema
that
brasileiro
know a lot
e
about the Brazilian
que tiveram a
system,
oportunidade,
and they are
logicamente, embora já
waiting
conhecessem,
for this
de aprofundar
opportunity
uma visão a
to
respeito do sistema
have
americano. Acho que era difícil
deeper
optar quem fosse o primeiro.
approach
Então, um
and
começa com
perspective
chave de
towards
outro e o outro
this
fecha com chave de
panel,
outro.
and
Como
then
quem está
they
do
are
meu
going
lado
to
esquerdo, no
close
meu coração está
everything
primeiro o
with
Gonzalo
a
Vecina.
golden key.
André, você
Now,
fica para segundo.
Mr.
Gonzalo, por
Vecina,
favor, seus comentários.
André, you will be second, and
Muito bem.
then Gonzalo, you're going to be first.
Boa noite a todos e todas. É prazer estar aqui nesse evento.
Good evening,
com
ladies
Maureen
and gentlemen. It's a pleasure to be part of this
Médici
event with Maureen and
e
the other
o
speakers
Claudio,
and
professor
Claudio.
Lottenberg. Eu acho que o sistema
I believe
eleitoral americano
the
é
electoral
mais simples do que o
US
sistema de
system is
saúde. Né?
simpler
Nós
than
temos
the
falado muito
healthcare
do sistema
system. We have
eleitoral,
been
mas o
speaking a
sistema
lot
de
about the
saúde é
election
pior,
system in
mais
US, but I
complicado.
believe the healthcare system is
Eu,
quite
quando eu vou
complex,
dar
more
aula sobre o
complicated.
sistema de saúde,
Because when
sistema
we
de
talk
saúde, você fala, olha,
about the
nós vamos falar de
healthcare
sistema de
systems,
saúde e vamos
let's
falar
talk
de um
about
não
the
sistema. O não
healthcare
sistema é o
system and the
americano. Né?
non-system. And the
Ele tem um pouco
non-system
de
is the
tudo
US
e não
system
cobre
because has a
direito
bit
nada.
of
Né?
everything and does not cover
É
everything
óbvio que tem coisas muito
properly.
importantes
So,
nos
of course,
Estados
there are
Unidos e que
many
nós temos
key
muito que
important
aprender lá.
aspects in the United States. We have a lot
Tem
to
a
learn
armadilha
from
do
there.
custo,
We
né?
have also the cost
Um sistema de
trap
saúde
because
extremamente caro.
they have an extremely
O PIB dos
expensive
Estados Unidos
healthcare
hoje situa-se
system.
em
The
torno de
GDP
20
in the
trilhões de
United
dólares.
States is about
18%
$20 trillion,
disso é gasto
and
na saúde.
18% of that
É
is
gasto
spent in
impensável
healthcare. So it's
por
an
Canadá que está
unthinkable
ali do lado.
expenditure for Canada, which is just
Tem um sistema
beside
de
the
saúde com
country.
melhores
So they
resultados que o
have a
sistema de saúde
better
americano.
healthcare system in
Mas
terms
todo
of
mundo tem o que
results
aprender
against
com o
the
sistema de
US
saúde
system, but
americano,
everybody can
particularmente em
learn
algumas
from
áreas em que a Maureen
US
deixou muito
healthcare
claro isso.
system. And Maureen
Na
explained that
produção e
very
uso de
clearly in the
dados, o
production
sistema
and
de
use
saúde
of data.
americano
The
é
US
exemplo a
healthcare
ser
system
olhado de
is a
perto.
role model to
E
be
nós precisamos de muitos
studied,
dados que
and we
nós não
require a
estamos
lot of
produzindo
data,
esses
and we are
dados
not
no Brasil.
generating such data for
O
Brazil.
problema que eles têm lá de
The issue they
interoperabilidade
have there of
entre sistemas informatizados
interoperability
é
among the
problema
systems they
mundial.
have in place,
Nós
that's a
não
worldwide
conseguimos
issue.
enfrentar
We
de
are
maneira
not able to
adequada
face
a construção
properly
de barramentos que
the building
permitam
of some
uma adequada
barriers that will
interoperabilidade entre
provide the
sistemas que
proper
deveriam conversar
interoperability
com
between the
segurança
systems that
para os
should
dados
talk
do paciente.
safely
Ao
and
advento do
address the
blockchain,
data
talvez
connected with the
tenha algumas
patients.
respostas
Maybe
no futuro
they will have some
próximo
answers
para
in
que
the
nós
future,
possamos ter uma
so
maior
we will have a higher
interoperabilidade,
level of
garantindo
interoperability,
a
ensuring
segurança
the
e a privacidade
safety
dos
and
dados para os
privacy of
pacientes.
data for the
Experiência
United
importante
States.
que os
So
Estados
the
Unidos estão
chain,
fazendo,
the
que merece
block
toda a nossa
could
atenção,
address that.
é a
So
saída do
what
fee for
deserves our
service. Né?
attention is the
Então,
fee
eles têm uma
for
experiência muito
service
grande de trabalhar com os
system. So they
DRGs.
have a
Os
high level of
DRGs, como a Maureen
experience
falou, têm
leading
uma
with the
certa
DRGs,
semelhança
as Maureen
com o
mentioned.
pagamento por
It's
procedimento,
similar
só que
to
nós
the
enterramos o pagamento por
payment
procedimento no
per
Brasil
procedure,
com a
and
espiral
we
inflacionária. Né?
just
Então, na
blocked
verdade,
that
hoje,
with the inflation
nós temos que zerar.
momentum we gained. So we need to
O
achieve
sistema de
zero
pagamento por
level.
procedimento é um
And
sistema
the payment
inteligente,
per
só que
procedure is a
ele
smart
foi
system,
totalmente
but
destravado,
it
desatualizado
was
por causa das políticas inflacionárias. E hoje
disrupted
não
due
existe
to the
isso.
inflationary
Eu não acredito que isso
policies,
possa
and
ser
I do not believe we
utilizado
have it available in
no
Brazil, and
próximo
it
passo
could
que
be
nós temos que
used.
dar. Sair do
And
fee
this
for
could be the
service.
next
E no setor
step. So leave
público,
the fee
o
for service. In
caminho
the public
é
sector,
captação
we require
e o orçamento
captation
global. Não tem
and
muita
a
saída para o
global
setor público no
budget.
Brasil,
We
na
do
minha
not
opinião.
have another way
E
out for the
através
public
da
sector in Brazil,
construção
in my
de
opinion, and
parcerias.
through
E a administração
partnerships,
pública
because
produz
we
uma
have the
ineficiência
public
fantástica.
administration that
Então,
generates a
nós
high
vamos
level
ter
of
que
inefficiency.
buscar
So
o
we
aumento
will
da
need to
eficiência e
increase the
a
efficiency
busca do aumento da
level,
eficiência
and with
já
this
tem
increase in
alguns
efficiency,
indicadores. Né?
we'll have
Quer dizer,
some
trabalhar com as
KPIs.
PPPs Hospital do
work
Subúrbio
with
na
the
Bahia, que teve a
TPPs
consultoria do
in the
Banco
suburban
Mundial,
hospital in
é
Bahia
uma
that
solução
had some
muito interessante
funding from the
e é
World
uma solução que
Bank is
enfrenta
an interesting
essa questão
solution and
do
will
pagamento
face these
com o quê?
aspects connected with
Dados.
payment
Basicamente, o que
with
foi
data.
construído é
Basically,
belíssimo
what
do
they have
sistema
there is
de
a wonderful
acompanhamento dos dados
system
produzidos
of
pelo Hospital do
following
Subúrbio.
up the data
Esse é
that are
a resposta.
generated
Temos que
by
olhar para o
the
Hospital do Subúrbio.
suburban
Né?
hospitals. So we need
Sair
to
desse
look
mimimi de que é
at that.
privatização,
So
é não sei o
stop
quê.
all this talk
Vamos
that
de dente shopping.
privatization is this or
Queremos
that.
gatos que
We
caçem
need to
ratos.
capture
Ponto.
data in order to solve
Essa
the
questão da
issues.
acreditação e da qualidade é algo com que nós já
Licensing
estamos aprendendo.
accreditation aspects
Só
is
que nós
something we
temos
have
aqui
been
no
learning
Brasil
from.
alguma
But
coisa entre
we
6 mil e
have
7 mil hospitais,
approximately
a gente
between
não sabe mais ou menos
6,000
quanto é,
7,000 hospitals.
mas
We do not have the
somente
proper
300
figure,
ou
but
350
only
hospitais são
300
acreditados.
or 350 are
Uma gota d'água no oceano.
accredited
Acreditação
hospitals.
é
Accreditation
fundamental.
is key, is
Sem
fundamental.
acreditação,
Without
infelizmente, não dá para
accreditation,
oferecer
unfortunately, we
segurança na
cannot
assistência.
support
Então,
and
nós
provide
estamos
safety in the
matando os nossos
healthcare. We are
pacientes porque
killing
não
our
temos
patients because
segurança
we
nos
do
nossos
not have
hospitais.
enough safety
E a
at the
questão da
hospital
inovação
setting.
e de
Innovation
estar na
aspects as
crista da
well.
onda, que é uma questão
This
importante
is
também que
a
os americanos têm.
hot
Nós
topic, and the
tentamos seguir
Americans,
atrás, mas vamos
they
muito
have it
atrás. Né?
available and we are
Então,
lagging
hoje ainda no SUS nós não
behind,
incorporamos a
really
videocirurgia.
lagging
Que
behind that.
dirá
We
da
are
cirurgia
incorporating the video
robótica?
surgery,
Então,
and who
temos muito
knows
que
when
andar, muito
robotic
que
surgery
trabalhar.
will be
Meus 10 minutos
incorporated in
acabaram.
our practice.
Eu vou
My 10
aguardar
minutes
os
is over,
comentários
so I will
sábios do
wait
meu amigo
for
André.
the wise comments of my friend André.
André Médici, por favor.
André, you have the floor.
Bom, depois
Well,
da excelente exposição
after the
da Maureen e dos excelentes comentários do Gonzalo também, eu fico sem muitas palavras para o que dizer, né? Então, eu vou tentar basicamente sintetizar alguns pontos que eu acho que são interessantes no que diz respeito a dois aspectos da realidade recente, que primeiro a questão da cobertura. Eu acho que foi muito interessante o movimento de aumento da cobertura de saúde, de seguros de saúde, que teve na época o plano Obama, embora a Maureen com toda propriedade falou que isso realmente é uma questão que tem que pensar do ponto de vista da qualidade. Você está cobrindo mais pessoas nos Estados Unidos, mas a qualidade dos planos realmente ela deixa um pouco a desejar. Então essa é uma questão que teria que ser pensada também, mas a cobertura foi muito importante. E a segunda questão que eu queria colocar é um pouco a questão das formas como os Estados Unidos têm enfrentado recentemente também a questão da pandemia, porque eu acho que existem outros aspectos da saúde, do sistema, que deveriam de alguma forma ser incorporados nessa questão. Então, no que diz respeito à primeira questão, o que a gente pode dizer, quando a gente compara os dados entre 2000 e 2009 de cobertura de planos de saúde, esses são dados do Aceso, né? As pessoas sem seguro-saúde aumentaram entre 2000 e 2009 de 13% para 17% nos Estados Unidos. Houve um aumento brutal, né? E nesse mesmo momento, os gastos de saúde dos Estados Unidos aumentaram de 13% para 17%. Então, você teve um duplo movimento no início desse século, uma redução da cobertura de plano de seguro e um aumento enorme do gasto. Ou seja, o sistema estava criando realmente um espectro de ineficiência muito grande. O Obama, e isso eu gostaria de falar com toda sinceridade, que ele se comprometeu com a questão de ter uma cobertura universal nos Estados Unidos, e para tal ele aumentou o asseguramento através do que a gente chama de Affordable Care Act, ACA, que foi aprovado em 2010, criando, nesse caso, a obrigatoriedade em ter um seguro-saúde através da empresa, do indivíduo, que através de subsídios fiscais, quer dizer, aquilo que a Maureen colocou, uma parte desses recursos passaram a ser basicamente destinados a planos que eram subsidiados. Do ponto de vista da eficiência, né, o Obama se comprometeu, de alguma forma, a aumentar a eficiência do sistema através da ideia de Integrated Healthcare. Então, as chamadas Accountable Care Organizations, né, ACOs, que foi um modelo que cresceu muito. A Maureen escreveu um artigo, deu uma entrevista fantástica para o blog Monitor de Saúde, a esse respeito, que eu acho que todo mundo deveria ler, é uma referência essa entrevista que a Maureen deu no meu blog. Eu gostaria muito que vocês lessem, mostra claramente como é que esse processo foi um processo muito interessante do Integrated Healthcare, e essa é uma questão importante para o Brasil. Então, entre 2009 e 2016, a porcentagem de pessoas sem seguro-saúde se reduziu, vejam bem, de 16,7% para 8,6%. E o gasto com saúde aumentou somente de 17,3% para 18%. Então, você teve um gasto de saúde que foi praticamente flat, não, ele não aumentou, e a cobertura dobrou, né, do ponto de vista que a cobertura não é que a cobertura dobrou, com pessoas sem seguro-saúde se reduziu pela metade. Então, foi um movimento muito interessante que aconteceu nesse momento. Eu diria que o governo Trump, ele tentou desmontar o plano, embora não tenha conseguido, a Suprema Corte não deixou de alguma forma, mas de todos os modos, dentro da administração do governo Trump, o número de pessoas sem cobertura de saúde voltou a aumentar de 0,6% em 2016 para 9,2% em 2019, que são os últimos dados. Em fevereiro e março desse ano, 2020, cerca de 5,4 milhões de pessoas já perderam seu seguro-saúde em função da questão da pandemia. Então, a gente sabe que isso é um problema conjuntural, mas é uma questão que tem muito a ver com a forma pela qual você não pode descontinuar determinados tipos de políticas que estão, de alguma forma, dando resultado, né? A ideia é que a coalizão de Joe Biden que volta à discussão a proposta de modificar os planos sobre a questão que a Maureen colocou. E, basicamente, as propostas que o Biden tem colocado são propostas polêmicas, têm que ser discutidas, mas uma delas foi recuperar uma questão que tinha sido tirada do plano Obama, inicialmente, que é a Public Option. Não? Que a Public Option é um seguro, né, que vai sendo com prêmios que são decrescentes de acordo com o nível de renda das famílias. Então, famílias com nível mais baixo vão pagar muito pouco e vão ter um subsídio maior. Essa seria uma das questões. As pessoas, por exemplo, que ganham menos de 138% do nível de pobreza, vão ser automaticamente matriculadas no Biden em determinados programas, instituições, né, através de Seguridade Social, escolas pública poderá fazer ter acesso a esse plano. E com isso, eles esperam recuperar um pouco a cobertura dessas pessoas. O Biden também propõe mudanças no ACA, eliminando o limite de 400% de renda, que é a elegibilidade do subsídio fiscal, que anteriormente desqualificava algumas pessoas de classe média ou famílias que tinham um determinado nível de renda. Isso era muito ruim para pessoas de nível mais elevado em determinados estados, né, de receber assistência para a sua cobertura de seguro-saúde. Ele vai reduzir também o limite de custo da cobertura de saúde, que hoje está em torno de 9,86% da renda para receber esse subsídio, até perto de 8,5%. São propostas, são questões que vão ser discutidas. Mas é interessante a gente ver essa primeira leva de propostas que o Joe Biden porque são coisas que são interessantes. Né? Outra medida que está sendo proposta pelo Joe Biden é proibir os prestadores de colocar seus equipamentos fora da rede, distinção de que os pacientes não têm controle de serviços que vão utilizar. Por exemplo, se você está numa situação de emergência, você vai utilizar o primeiro que você vai ter. E nesse caso, hoje em dia, se esse provedor está fora da rede, os planos podem dar mais. Então, essa é uma questão também que ele pretende eliminar, porque vai fazer com que o custo do seguro fique um pouco. O Joe Biden também pretende investir muito nas áreas de medicamentos prescritos, cujos preços são muito elevados nos Estados Unidos. Né? Então, isso inclui pelo menos 3 medidas, né? A redução de lançamento de medicamentos que não enfrentam concorrência. Hoje em dia, a gente tem esses medicamentos biológicos, biotecnológicos, todos eles saem praticamente com monopólio. Então, isso daí faz com que o preço seja qualquer um. Ele vai tentar fazer com que esses preços sejam mais moderados. A redução dos preços de marcas de biotecnologias e medicamentos genéricos, que têm preços abusivos em relação à inflação, e a permissão dos consumidores em comprar também medicamentos em outros países, porque hoje em dia existe um mercado muito fechado dentro dos Estados Unidos para a compra de medicamentos, e também eliminar os incentivos fiscais para os gastos com propaganda de farmacêuticos para o fornecimento de medicamentos genéricos de qualidade. Essa é uma outra questão que está dentro da proposta dele. Né? Enfim, essa é a proposta que eu acho que é mais polêmica, né, porque a esperança de vida está aumentando, o Biden
controversial
quer reduzir a idade de
proposal because he
elegibilidade do
wants to
Medicare de
reduce
65
the
para 60 anos,
eligibility age
o
from
que
65 to
ampliaria o
6
acesso
years old, 60 years old, which would enhance the access of 20 million Americans that retired early. Because if life expectancy is increasing, probably this process will be even more difficult to be included. So I believe these are the questions we need to address. Currently, we are facing a change in the U.S. healthcare structure, and many of the proposals will just consolidate what we had at the NCA time that started up at the Obama administration. So they will try to solve the issues created by Trump in Medicare. And something that I would like to mention, and that's very brief, is that the U.S. government had a major financial support for the COVID, $3 trillion, and this will make the public deficit in 2020 would increase in 14% of the GDP, which is a huge share for the United States. And many have accused the government administration of lack of transparency, how the resources are being used. But the key issue for me is the lack of transparency in the use of resources, and that's due to a lack of communication between the government. Sorry, I lost his sound. So the administration of this pandemic took to a level of death that could be controlled based on the studies with some agencies. We could prevent 130,000 deaths in the high level of deaths we have with COVID in the United States. So with simple measures, the use of masks, they had a delayed in an overall response, and some public health practices that were not taken seriously while they were being implemented. And the study was conducted by Columbia University, where they analyzed some questions that could have real risks and could be implemented. So there was failures in ensuring strategic inventories, medical supplies and devices, shortage of resources and financial incentives for testing, checking treatments available, and check the need of self-quarantine. And the population is not with a high level of awareness towards the disease. And there is also some unproportional issue. And we have this assessment of ANAP hospitals in Brazil, and I was amazed how they are recovering very fast with the COVID environment. They made a huge transformation very fast, but the American Association will have a loss of 320 billion of income against 2019. In the first term of this year, the healthcare system had an increase in the hospital stay, and when we have chronic patients, we have some mortality issues connected with the patients, and 20% of the volume of outpatient procedures also were reduced. And this happened in Brazil because during COVID, and this is something I've been following up, the unemployment in healthcare in Brazil is increasing. Amazingly enough, is increasing, and these are data from the Ministry of Health. In the United States, there was a loss of 1.4 million losses in terms of employment in healthcare. And Maureen mentioned there were areas where we have shortage, which is the case of the nursing professionals in the United States. These were things that should be reanalyzed, because in the way this impact
of COVID happened in the beginning was quite complex. It's interesting to see that the United States was considered in 2019 by a Johns Hopkins analysis the most prepared country to face a pandemic according to the international rules, guidelines. But in July, another survey conducted by Forbes, based on another survey institute, the United States was ranked in the 54th position. So they had a really mediocre answer, so to speak, to the pandemic. So these are the topics that I would like to be discussed. And I believe I exceeded my 10 minutes. Thank you.
Unfortunately, we don't have much time to discuss because I think that all the comments and considerations were brilliant. But let me go back to you, Maureen. And of course, we are here to try to mirror the US system and see what we can use of it in the Brazilian system. So if you had the opportunity, Maureen, to interfere, making a decision in the healthcare system, considering everything that you presented to us and knowing the Brazilian system as you know it, which of the two systems would be easier to create a added value medicine, a value-based medicine? Which of the two?
Well, as André has said, the U.S. has limitations, and Gonzalo referred to the same thing. And there is no perfect system, but I think both systems have things to improve. I think there has to be, and I will take Brazil because that's what you asked me to. I think that Brazil could really benefit from the regulation, and that includes the accreditation and the data, because you know what's going on in the Brazilian system, right? You have a lot of small hospitals. Gonzalo mentioned this. You know, they're not very efficient. There's a recent PhD thesis in Minas Gerais University that shows the level of inefficiency, and I think it's a real issue for Brazil. So that's one thing. Secondly, I think the public system could be much more efficient and could be much better partner with the private sector. And I think that's where the gains are in Brazil. The OSS hospitals are an example that I use all over the world as one of the few PPPs that works really well. That's how it should be done. So there's some things that I think Brazil should do more of that Brazil already does. And then you have the Saúde da Família, which now has another name, I know, but that program is not integrated, right? So you have some great programs, but they're separated. And the US has the same problem. But quite frankly, I probably know more about where the Brazilian system should improve than the US system, because the US system is so rigid in some respects, because the regulation and the providers and the payers are already sort of gaming the system to the maximum extent. And there's not a lot of adjustment that they can make. And reducing costs right now means reducing salaries. And we know that's never going to happen. So that's, I think, one of the problems in the US. I think you can change, but it's going to be based on legal decisions of the Congress. And it's going to be more co-pays and things of that sort. In Brazil, there's more flexibility. There's more opportunity to change things. I mean, the Suburbio Hospital is a really good example. They've done a lot of things right. And there are other hospitals and hospital systems in Brazil that have done, Happy Vida has done really interesting work with low-income beneficiaries. So I think these are the kinds of things that Brazil could really harness and use more of, and I think be more effective and have this kind of impact that Claudio is putting on the table. So that's my 2 cents. So one of the things I did want to...
Oh, please go ahead. Oh, I'm sorry. He says, There is, unfortunately, a time constraint here to us. And you see, the speakers are just so great, and it's so wonderful to be here talking to you. I think Brazil has a huge challenge ahead of us, similarly to all countries, in fact, because and I think André said about the number of people included in the healthcare system in the US resulting from Obamacare. And when he said about keeping costs within a specific level and including more people, because you see, especially for us Brazilians, we understand health as being a right, a social right. We are all entitled to have good care. And I think Maureen just made reference to Programa da Família because it is an extension or something very close to it that can find a huge expression in what we call primary care with coordinated care, which solves what 85% of health problems in one single medical visit. So this is the kind of thing. And I have asked you that, Maureen, because I think that and all of us, we admire deeply United States innovation, its constant pursuit for technology and development. But in terms of funding, we know that has been a culture that encouraged much more cost than quality after all. And I think that Brazil, if the society and the politicians were willing to do so, of having better health policies and less politics in health, most probably we would be able to have a much better healthcare system. So thank you so much, Maureen, for your time, for your brilliant presentation. I think that you, once again, really show why we take you at such high value here. And as I've said, with distinguished speakers such as Gonzalo, Vecina, and André, Médici, I really wonder what my role is in this panel. Let's face it, brilliant minds, because all of us Brazilians who are interested in healthcare really deeply admire the three of you. So I'd like to thank all participants who have attended this session and all of you. So please receive my special thanks and warm regards. Thank you very much, everyone.